this meeting for Bangladesh about stress fractures. I'm sorry that I was unable to attend in person. Just so you know a little bit more about me, I trained in Canada. I'm originally from India, and after I did my training in Canada, I went to San Diego and did a fellowship with Dr. Resnick in musculoskeletal imaging. My main interests are in MR and in trauma, and what I'd like to talk about in this session with you is stress injury of bone. And we'll talk about the clinical manifestations, imaging manifestations, and also some of the biomechanics that underlie injury of bone in general. Stress injury of bone is a very important disorder, and we're seeing it more and more frequently. And my objectives in this talk are to define what a stress injury is, to talk about the different concepts of repetitive trauma and micro damage that lead to stress injury of bone. We'll talk a little bit about how bone repairs itself. I will define the differences for you between insufficiency and fatigue fractures, the biomechanical differences between cancellous and cortical bone, and then we'll focus on imaging, and I'll present an MR imaging classification that is widely used. So let's get started. First of all, when we talk about fractures, we divide them into three basic types. We have traumatic fractures in which a single episode of injury, usually a high-load injury, results in failure of the bone. We have pathologic fractures where a focal lesion, usually a lytic lesion like a metastasis, weakens the bone and it breaks after minor trauma or no trauma at all. In stress fractures, the injury is repetitive, and that is the key. It is repeated low-level injuries that result in bone failure, and they're subdivided into two types: fatigue, where the bone is normal, and insufficiency, where there's some problem with the underlying bone, usually osteoporosis. Now, when we talk about biomechanics of bone, or any material for that matter, any engineer in the audience is going to be familiar with this curve. It's called a stress-strain curve, and it shows the parameters that describe the strength of any material. It shows us how much load the material can sustain before it fails, and it shows us how much deformation, also called strain, the material can sustain. So materials can fail because they are deformed or because they're loaded. And we get a curve like this that shows you the failure points of a particular material. And bone is a very, very versatile material. It can tolerate significant amounts of distortion in its shape, as well as loading of the material before it actually breaks. Now, as you look at stress injuries in the United States right now, about 15 to 20% of all the fractures we see are actually caused by repetitive injury. And this is for many reasons. There's a big increase in people participating in sports, and that includes many older people who are participating actively in physical activities, and their bone is no longer as strong as it was when they were young. In a stress injury, you have repeated episodes of micro-trauma that result in weakening of the bone, and the bone is unable to heal itself, and you eventually wind up actually lowering the failure point of the bone. We refer to this as micro damage. So micro damage takes place in the scale under 1 millimeter, in the range of 100 to 500 microns. And it takes the form of micro cracks in the bone that are resorbed by your body as part of the healing process. And if this micro damage accumulates, in its initial phases, we'll see mild edema, subtle cracking starting to take place at the subchondral bone. But if you don't rest, the injury will wind up completing itself and developing a real fracture. So as we talk about bone and different materials in imaging, we tend to focus on them at a macroscopic scale. But much of the damage in stress injury when it starts takes place at this microscopic scale of the osteon and of the trabeculae. Failure obviously also takes place at the nanoscale in the collagen fibers themselves, but these really do not at this time have any in vivo imaging correlate that we can use. Here are some electron microscopy images, obviously done in vitro, showing this type of micro-cracking that's taking place within the bone. And our question really becomes, when should we call this a fracture? Because this type of cracking is going to occur at all of the different length scales that I just mentioned. In clinical practice, we are going to focus on the damage only when it becomes macroscopic. Now, how does your body heal itself from all of this micro damage that we accumulate through our activities of daily living? There's a very well-organized cellular unit that's referred to as the basic multicellular unit, which is the coordinated action of osteoclasts that resorb the bone, shown here in red, and osteoblasts, shown here in blue, that repair that damage. And you can see that this has a phase of resorption and a phase of filling in. Insufficiency fractures tend to involve the axial skeleton and the lower extremity. They are uncommon in the upper extremity. And the common causes I have listed here with the activities that are related to them. There are a number of different disorders that are associated with insufficiency fractures. The three that are best known are osteoporosis, previous bone irradiation, and osteomalacia, but there are a host of other disorders that can lead to insufficiency injury, and here in a young patient with an insufficiency fracture of the femoral head, the underlying disorder was a rare condition, in this case osteogenesis imperfecta. So there are a number of different disorders that we need to keep in mind. And because there are so many diseases associated with insufficiency fractures, the history is often confusing or unhelpful because they may have a coexistent other condition that actually delays the diagnosis. When people have a known disease, we tend to ascribe symptoms to that particular disease. So since these patients are often elderly and have many other medical problems, the diagnosis of insufficiency injury may be missed for some period of time. Similarly, patients who have a history of malignancy, who develop insufficiency injury of their bone for a number of reasons due to poor diet, prior irradiation, etc., we have a tendency to try to ascribe their symptoms to that underlying malignancy. So these tend to be diagnosed relatively late. Insufficiency fractures tend to involve the axial skeleton and the lower extremity. They are uncommon in the upper extremity. And the common causes I have listed here with the activities that are related to them. There are a number of different disorders that are associated with insufficiency fractures. The three that are best known are osteoporosis, previous bone irradiation, and osteomalacia, but there are a host of other disorders that can lead to insufficiency injury, and here in a young patient with an insufficiency fracture of the femoral head, the underlying disorder was a rare condition, in this case osteogenesis imperfecta. So there are a number of different disorders that we need to keep in mind. And because there are so many diseases associated with insufficiency fractures, the history is often confusing or unhelpful because they may have a coexistent other condition that actually delays the diagnosis. When people have a known disease, we tend to ascribe symptoms to that particular disease. So since these patients are often elderly and have many other medical problems, the diagnosis of insufficiency injury may be missed for some period of time. Similarly, patients who have a history of malignancy, who develop insufficiency injury of their bone for a number of reasons due to poor diet, prior irradiation, etc., we have a tendency to try to ascribe their symptoms to that underlying malignancy. So these tend to be diagnosed relatively late. of this entity. They initially described spontaneous osteonecrosis, but subsequently realized that this is an insufficiency fracture. And here we see from their article the microfracture that is taking place and failure at the subchondral bone plate. So while this can look a lot like avascular necrosis, when it's isolated to one area and there are no known risk factors, when the edema is very pronounced, you really should consider the possibility that this is an insufficiency fracture and rest the patient. You may bring them back for imaging in a 3-month follow-up and see if the changes have resolved or reversed. This happens in many parts of the body and it's gone by many names. We now know that transient osteoporosis of the hip is typically caused by an insufficiency fracture, and as we do more high-resolution imaging of the hip, some of the lines and bands that were not apparent when we were doing large field of view imaging of the entire pelvis can now become manifest. So these are a common entity that you should be aware of. Let's look at some areas where insufficiency injury is less common. This is a patient who has had a reverse shoulder arthroplasty. This is an interesting design that allows the shoulder to be replaced even in the setting of a completely atrophic rotator cuff musculature, and it relies instead on the deltoid being the main mover of the arm. And here we see on the follow-up that the prosthesis looks fine, but look at the orientation now at the acromion. It is low-lying and downsloping. And because of the overloading by the deltoid on the acromion, we have developed an insufficiency fracture, a well-recognized complication of the change in weight bearing that takes place as a result of this particular prosthesis. Here's another patient with a prosthesis. The immediate post-operative, everything looks fine. There's some soft tissue gas from the surgery. She comes back in a few months later and is having pain. The component looks fine, but look what's happened now at the ischium, where we have developed an inferior pubic ramus fracture. So the patient is very happy with the results of their arthroplasty. She's walking much more. She's in a physical rehabilitation program, but as a result, she now has developed a fracture. And if you look carefully, there's another fracture, more subtle, developing in the superior pubic ramus in the absence of any particular trauma other than remobilization. This is a patient with rheumatoid arthritis, and she's come in, and you can see here that she has some soft tissue fullness and erosion related to her disease at the calcaneus, some thickening of the proximal Achilles tendon, but I draw your attention to the insufficiency fracture in her tibia, manifest with this band of sclerosis. She also has a fracture starting here in her fibula. This was more of a conventional traumatic fracture, which is oblique and cortically oriented after a very minor trauma. So you can see that in a patient with an underlying disease, that things can get very, very complicated because your eye is distracted by all of the other features, and it's tempting to ascribe all of the changes related to rheumatoid arthritis. So it's easy to overlook insufficiency fractures when patients have underlying diseases. This is another patient with rheumatoid arthritis with multiple insufficiency fractures involving her iliac bone, both sides of her sacrum, and unfortunately these were not diagnosed for quite a long time, and this is after several months of pain. We can see that the right sacroiliac joint fracture is actually displaced. There's some soft tissue fullness in the iliacus related to it, and we have developed gas inside the bone. So intraosseous gas develops in chronic insufficiency fractures, presumably related to areas where the bone has become necrotic. It does not indicate that there is infection in the bone. So be aware of this. You will see this in the vertebra quite frequently in insufficiency fractures, where you see a vacuum phenomena in the broken vertebral body. but it is a finding in chronic insufficiency injuries. And here we can see the displaced sacroiliac joint and the number of fractures that's present in this poor patient. Diabetes, similarly, is a disease in which we see a large number of fractures. In the diabetic patient, these fractures can coexist with neuroarthropathy, which makes them more challenging to diagnose, and the patients may not present early in the course of their disease because they are insensate. So since they don't tend to have as much pain, the fractures may be diagnosed late. This patient did have some symptoms at this time. The X-ray shows mild osteoarthrosis with joint space loss. The fracturing is not apparent, and here on the follow-up we can see the fragmentation that's taken place in the bone, and here on the MR, subchondral fracturing that's taking place, and malalignment and intense edema related to insufficiency. So diabetics, when they do develop a fracture, do have a worse prognosis because they tend to collapse and displace. Here's a patient who's had radiation developing fractures, and radiation is another important thing to keep in mind because it reduces not just bone density, but it reduces many other parameters in the bone, including its ductility and its fracture resistance. And this is a progressive phenomenon that is related to radiation dose. But again, we tend to overlook these because we're always worried about an underlying malignancy. Now, the place where femoral or fractures are really a problem from insufficiency is around the area of the femoral neck. These can be subtle and challenging to diagnose on radiographs. And this patient is very osteopenic. The fracture line is pretty visible, but in some cases, especially early, they are very difficult to diagnose. Now remember that in this location, that fractures, whether they're caused from trauma or fatigue or insufficiency, they all have a rather similar appearance. They tend to involve the inner aspect of the femoral neck, and they tend to, again, cross those compressive trabeculae that I mentioned to you earlier. Excuse me. So in the femur, our primary compressive trabeculae run along the medial side. We have a more transversely oriented band of secondary trabeculae that are tensile. These can also fail, but less commonly. The primary failure we're going to see is across the